best way to predict your future is to create it. So what is the future that you want? Are you creating it? Are you already creating it? Nobody else will create it for you but you. And you are our future. You are not only your future, you are our future. And we are very glad that you are our future, because we are so confident that because of you, our future is bright. So yes, start creating your future from now. So with this, we start with the audiology, a very, very important part of ENT, very important part of ear. Many questions are asked from this, and this is a diagnosis part. Why are we doing this in the beginning? And yes, I recommend that before you do the diseases, see the audiology part, because this covers all the diagnosis part. Once you have done this part, the diagnosis of all the diseases is already there with you. So then it becomes very simple for you to do the diseases. So what is now we are starting is audiology. Now, whenever there is a sound, it is picked up by the pinna. It then goes to the external auditory canal, then to the tympanic membrane, ossicular chain, footplate of stapes, oval window, organ of Corti, auditory pathway, auditory cortex. Yes, quickly repeat this for me. Yes, sound has come, picked up by pinna. Next, very good, tell me quickly. Yes, external auditory canal. Next, tympanic membrane, ossicular chain, footplate of stapes, organ of Corti, auditory pathway, auditory cortex. Now, where the sound is getting collected in the pinna, getting transmitted in the external auditory canal, in the middle ear, up till the footplate of stapes, what is happening is conduction of sound. So, from the pinna till the footplate of stapes is what is known as conductive pathway. Which means if there is any defect from the pinna till footplate of stapes, what will that hearing loss be known as? Conductive hearing loss. Now, when the sound goes into the inner ear, what is happening in the inner ear? Yes, we know what happens in the inner ear. Mechanical energy of the sound gets converted to electrical impulses, and what is that known as? Transduction. So what is happening in the inner ear is the transduction. That is the sensory apparatus of hearing. And beyond that, the nerves, when the electrical impulses go to the nerve, that is what is known as neural pathway. If there is any defect in the inner ear, in the organ of Corti, what will that hearing loss be known as? Sensory neural or only sensory? Yes, that is the sensory apparatus of hearing. So that is what is known as sensory, or it is known as cochlear hearing loss. Any defect beyond that in the nerve is what is known as neural or retrocochlear hearing loss. Yes, so let us write this. From the pinna to the stapes, to the footplate of stapes, this is what is known as conductive pathway, and any defect here will result in conductive hearing loss. Now, any defect in the inner ear, what is happening? Transduction. Transduction, inner ear means what? Inner ear is organ of Corti. That is what is in the inner ear for hearing, right? So, organ of Corti, transduction is taking place. Any defect here will known as cochlear hearing loss. Cochlear also known as sensory hearing loss. Sensory hearing loss. And any defect beyond that in the nerve, that is a neural pathway. Neural pathway. Yes, so if there is any defect here, this is known as neural or retrocochlear hearing loss. This is known as retrocochlear hearing loss. So what are the pathways? We have the conductive pathway, then we have the sensory or the cochlear pathway, sensory pathway, and then we have the neural pathway. We have the neural pathway. Conductive pathway is from pinna to footplate. Sensory is in the organ of Corti, and neural is in the starting from the nerve going to the auditory pathway. So the auditory pathway. Okay, so now we know what are the different pathways for transmission of sound, and if any defect in this pathway, where is the defect and what we call it. Okay, now when the sound is collected in the pinna, it is transmitted to the external auditory canal, Ultimately, the transduction of sound takes place in the inner ear. Then what at all is the need for middle ear? Why not sound directly be collected from the pinna, transmitted to the external auditory canal and ultimately sent to the inner ear for transduction of sound? Why at all the need for middle ear? So many walls, so many things in the middle ear, all that headache will go for us, yes? Yes, because what is the medium of transmission in the external ear? That is air. What is the medium of transmission in the middle ear? Again it is air. What is the medium of transmission in the inner ear? Yes, in the inner ear we have fluids. What fluids do we have? Yes, we have the perilymph, we have the endolymph. Yes, when the sound goes from one medium to the other, when the sound goes from air medium to the liquid medium, what happens is most of the time, yes, most of the sound, 99.9% of the sound gets reflected back. So you must be thinking, what is all this? Air to liquid medium, most of the sound gets reflected back. Have you not noticed it? Have you not seen it? You have seen that. You have noticed that very, very commonly. Whenever you are swimming, whenever your head is under the water, whatever a person who is standing outside, no matter how loudly he is speaking, how loudly he is shouting, do you hear it? You don't hear it. Why? Are you not hearing, or is that person not speaking? Both are perfect, but the sound is going from air medium to the liquid medium. So what happens is that most of the sound gets reflected back. That is exactly what is happening in a ear. Sound is going from air medium to liquid medium. So most of the sound is getting reflected back. So to overcome this is the presence of middle ear. What the middle ear does is, instead of letting all the sound get reflected back, it increases the force of sound so that more of sound can enter the inner ear. And this mechanism of the middle ear is what is known as impedance matching. Impedance means resistance. So it matches the resistance of flow of sound on both the sides, air and liquid side. Now also, one of the function of the middle ear is dampening of sound. Does the middle ear dampen the sound also? Its function is to conduct sound. Does it dampen the sound also? Yes, it dampens the sound also. Which sounds? Only very loud sound. How loud? More than 70 decibel, above your threshold, by a reflex which is known as stepedral reflex or acoustic reflex. Yes. So what the function of the middle ear is? Both. It dampens also and it amplifies also. So that is why this function of the middle ear is what is known as transformer action. Transformer. What does a transformer do? When we put it to electrical appliances, whenever the electricity is less, it increases it, sends it forward. When it is more, it decreases it, sends it forward. Same is what the middle ear is doing. Loud sound decreases it. Any sound, it amplifies it. But what is the main action of the middle ear? Is it amplification or dampening? Main action is amplification. Why do I say main action is amplification? Because are we surrounded by such loud sounds all the time that stepedral reflex should be activated all the time? No. So the main action is amplification, because each and every sound that enters our ear, before it reaches the inner ear, it needs to be amplified, because there is a change of medium, because of which most of the sound is reflected back. So it has to amplify the sounds before it reaches the inner ear. So that is the main function of the middle ear. So that we need to remember. The middle ear function is known as impedance matching. Impedance matching, also known as transformer action. Transformer action. Now, how does this transformer action take place? How does any sound, when it goes through the middle ear, get amplified before it reaches the inner ear? For that, we have to know of two ratios. The first is what is known as the aerial ratio, also known as hydraulic ratio. So what is that? Aerial. It is known as aerial, also known as hydraulic. Hydraulic. The aerial name itself tells you aerial means something to do with the area. Now what is this? Whenever the sound goes to from the external auditory canal to the tympanic membrane, now the tympanic membrane vibrates and the ossicular chain is attached to the tympanic membrane through the malleus to the incus and through the stapes. So when the sound goes from the external auditory canal to the tympanic membrane, it leads to the vibration of the ossicular chain. Ultimately, it reaches the footplate of stapes. So are you seeing that there is a gross difference between the area of the tympanic membrane and the footplate of stapes? Yes. Can you tell me what is the effective vibratory area of the tympanic membrane? Yes, the effective vibratory area of tympanic membrane is 55 millimeters square. And now I feel like asking you, what else is 55 in the tympanic membrane? Very good, the angle with the horizontal. And what is the footplate surface area? Footplate surface area is 3.2 millimeters. This 3.2 millimeters you need not remember, yes? But the 55 millimeters square, very important for you to remember. Now, what we are seeing is that sound is getting concentrated from such a large area to such a small area. So, when the sound gets concentrated from such a large area to such a small area, the force of the sound increases. It increases depending upon the difference of the surface area of these two surfaces. Have you not been using this aerial ratios somewhere very commonly? Very commonly? Now, whenever we want to put a nail in the wall, we have seen how the nail looks. Yes, it has got a pointed tip which goes inside the wall, and it has got a broad end where we hit. Now, why is the other end of the nail broad? Why is that also not pointed? What? Okay, so that we can hang something on it. No. Why? Yes, because when we hit the broader surface and when all the force gets concentrated on the pointed surface, the force automatically increases. How much it increases depends upon the difference of the surface area of these two surfaces. So same thing is happening here. The sound is getting concentrated from large area to the small area. So the force automatically increases depending upon the difference of the area of these two surfaces. So the more the difference, the more the sound will increase. The more the force will increase. Yes, so what is the aerial ratio? Aerial ratio is when we divide the area, these two surfaces, and that is 17. That is 17. The ratio is 17. Now, the second thing that is important here is what is the lever ratio. Now, what is the lever ratio? The lever ratio is that there is a difference in the length of the handle of malleus and the long process of incus. Incus, long process. Yes, we can make out. Yes, what is smaller? The incus long process is smaller. How much smaller? It is 1.3 times smaller. So, when the malleus moves, the incus moves 1.3 times more. That increases the force 1.3 times more. How does that happen? Okay, just imagine that there are three people of same height, same width standing in a line. The third pushes the second. So, what will happen? The first will automatically be pushed with the same force. Now, what if the first or if the second is a smaller child? It's a small child. So the same force will make the small child move farther away. The same thing is here. Since the incus is smaller than the malleus, if both of them were of the same length, how much malleus will move? Incus will also move that much. But since the incus is smaller, it moves more when the malleus pushes it. So how much it moves more depends upon how much small it is. So that is 1.3 times smaller. So the lever ratio is 1.3. So when we multiply, we take the product of aerial and the lever ratio, we get the total transformer action. So that is 17 into 1.3, that is 22. That is 22. So this is what is the transformer action. Now here we also need to know something else, and that is what is phase difference. Now what is phase difference? Phase difference. Now what is phase difference? Yes, you must have heard of it. So let us see what this phase difference is. Now whenever the sound goes through the tympanic membrane, it goes through the ossicular chain to the footplate of stapes. So what happens is, next to the footplate of stapes, there is compression, and then it comes in the reverse direction. The round window moves out. So there is rarefaction at the round window. Because of this opposite movement, there is shearing action created. Basilar membrane moves. Hair cells of the organ of Corti get stimulated. Sound is transmitted. Now, what happens is that since this is going through the ossicular chain to the oval window, this is the preferential pathway. But whole of the tympanic membrane moves, which means that some sound, also because of vibration of the tympanic membrane, directly goes to the round window. But since the ossicular chain is the preferential pathway, sound reaches the oval window much before it reaches the round window. So when the sound is present at the oval window, at the round window sound is not yet reached. So at the level of oval window, compression; at the round window, rarefaction. Now when the sound reaches the round window, the sound at the oval window is over. So compression at the round window and rarefaction at the oval window. So in any case, what is happening is opposite movement has to occur. So that is what is known as phase difference. That is what is that whenever the sound reaches one window, it is in a different phase than the other window. One window is in compression, the other is in rarefaction. So what will happen if both the windows will get exposed at the same time? Yes. So then what will happen? Compression at both the windows, sound will cancel each other. So then there will be hearing loss. So that is why the perforations of the tympanic membrane which expose the oval window and the round window at the same time, they cause a much higher hearing loss than any other perforation of the tympanic membrane, because the phase difference is lost. So now what we know is that the middle ear is responsible for amplification of sound. Middle ear is responsible for impedance matching, and how this amplification occurs, that also we have seen, that occurs through the transformer action. So quickly, can you tell me what are the two ratios which are important for transformer action? Yes, very good. The aerial ratio. How much is the aerial ratio? What is the vibratory area of tympanic membrane? 55 millimeters square. What is the aerial ratio? Yes, that is 17. And what is the lever ratio? 1.3. What is the total transformer action? 22. So with that, now we start the test of that we do for any hearing loss, the audiological test. So here is a patient who has come to you with a complaint of decreased hearing of right ear. Okay, so patient is telling you that I'm having decreased hearing. So the moment you hear that the patient has decreased hearing of one ear, immediately the complete picture of ear comes to your mind. And now what you want to do is you want to localize whether it is a disorder of the external ear, the middle ear, inner ear. Once you localize, then you are able to treat the patient accordingly. So whenever there is any patient who has come to you with hearing loss, if there is any defect in the external ear, in the middle ear, where you can immediately see and you can make the diagnosis, you see and you make the diagnosis, you treat the patient, yes. But if there is the ear, everything is appearing, you are not able to find out what the defect is, then you need to find out what the hearing loss is, whether it is a conductive hearing loss, whether it is a sensory hearing loss, whether it is a neural hearing loss. So then that will accordingly tell you the site of lesion, and you can treat the patient accordingly. So whenever there is a patient who has come to you with hearing loss and you want to find out the site, what is the most basic test of hearing that you do? Yes, all of you must be doing it. If you're not doing it, do it. Yes, and see how it is done. What is that test? Yes, the tuning fork test. I am sure all of you have seen a tuning fork. Yes or no? Yes. What is the most common frequency of tuning fork that is used in the OPD? Yes, we have the 512 Hertz. Now, why is the 512 Hertz used most commonly? What are the other frequencies that are used? Yes, other frequencies, we have 128, 256, 512, we have 1024, that's all the double, yes? 128, double 256, double 512, double 1024. Now, why do we use specifically then only 512 Hertz? Okay, the ear is sensitive to what frequencies? From 20 Hertz to 20,000 Hertz. But are all these frequencies important to us in hearing? No. The frequencies that are important to us in hearing are the ones that we use in speech most commonly. So they are known as speech frequencies. So which out of these are the speech frequencies? Yes, the speech frequencies are 500, 1000 and 2000. So the speech frequencies are 500 Hertz, 1000 and 2000. So out of these, the most common frequency that is used is, out of these tuning fork, the most common frequency that is used is 512. So can you make out why 512 is used? Yes, because it falls in the speech frequency range. And also, what will happen if you will use a frequency less than 512? If you use a 128 or 256, what will happen? Do you take any tuning fork for medicine posting? Have you taken? Yes, there you take. Why did you take it there? Yes, to sense for vibration sense, which means a frequency less than 512 has more of vibration sense. And a frequency more than 512, it dampens very fast. If it dampens very fast, the sound is over very fast and you cannot compare it. So that is why the most common frequency that we use is 512 Hertz. Okay. So now what do you do with the tuning fork? I have taken the tuning fork. Now listen very, very carefully. Be very, very attentive. If you understand this here, it is so simple. And if you do not understand it here, believe me, you will never understand it. And there are so many questions, almost every year, tuning fork questions, almost every year, audiology questions are always asked, be it AIIMS, be it JIPMER, be it PGI, be it any exam, NEET, Yes. So what do you do with the tuning fork? So we take the tuning fork, we vibrate it. We place it in front of the pinna. So now when we place it in front of the pinna, what happens is sound vibrations are collected by the pinna. Yes. Now next pathway, you will tell me. Yes, very good. External auditory canal, tympanic membrane, ossicular chain, footprint of stapes, organ of Corti, auditory pathway, auditory cortex. Yes. So now the sound reaches the auditory cortex and I sense the sound. Yes, and we sense the sound. So now, right now, when I'm talking to you, you are hearing me. Yes, how is the sound going to your ears? In the same pathway. It is from the air, it is going in the same pathway, external ear, middle ear, inner ear, yes, to the auditory pathway, and you're hearing it. And this is what we call as air conduction. The sound that enters our ear through the air is what is known as air conduction, which means air conduction is a measure of which pathway? Can you tell me? Air conduction is a measure of which pathway? Yes, only conductive. Only conductive. After that, nothing. No, it has to go from the conductive, from the external ear, middle ear, then to the inner ear, then to the auditory pathway, and only then we will be able to sense it, which means air conduction is a measure of all the three pathways, conductive, sensory and neural pathway. Is that clear? So right now when you're hearing me, it is going through which pathway? All the three pathways, and that is what we call as air conduction. So let us write this down. Air conduction is a measure of conductive plus sensory plus neural pathway. Now in the conductive pathway, from the pinna till the footprint of stapes, what is the most important part of the conductive pathway? Is it the pinna, the external ear, or the middle ear? Most important. Yes, most important is the middle ear. Why do I say most important is middle ear? Because what is taking place in the middle ear? Amplification. Amplification of sound is taking place in the middle ear. So that is why we consider it as the most important part of the conductive pathway. Okay, now again I take the tuning fork, I vibrate it, and now I place it over the mastoid. So what happens? The vibrations are now transmitted to the bone of the skull. The skull vibrates. When the skull vibrates, the cochlear fluids move. The cochlear fluids, why they move? Because the cochlea is present in the bony labyrinth. So when the bone of the skull vibrates, bony labyrinth is also part of that, of the skull. So when the skull vibrates, the cochlear fluids move, the basilar membrane gets stimulated, the auditory nerves get stimulated, auditory pathway, auditory cortex. This is what we call as bone conduction. So bone conduction is a measure of which pathway? A sensory and neural pathway. So bone conduction is a measure of sensory plus neural pathway. Sensory plus neural pathway. Okay. Now what do you think will always be better? Air conduction or bone conduction? What will be better always? Think, tell me, air conduction or bone conduction? Is there any change of medium occurring in the bone conduction? No. Is in the bone conduction sound not going from bone to liquid? Yes, solid medium to liquid medium. Is there not change of medium occurring? Yes, it is occurring. But is there any amplification taking place here? No. What is there any change of medium occurring in the air conduction? Sound is going from air to liquid? Yes or no? Yes. But is amplification taking place here? Yes. Where? In the middle ear. So, because of amplification taking place in the middle ear, ultimately more of sound is reaching the sensoneural pathway than the sound that is reaching directly the sensoneural pathway. Yes. So, that is why always air conduction is better than bone conduction. Air conduction is better than bone conduction because of what? Because of amplification. Because of amplification where? In the middle ear. Which means as long as the middle ear is normal and as long as the sound passes through the middle ear. Yes, middle ear is normal and the sound passes through the middle ear. Amplified sound will go to the inner ear and the sound will be heard better than the sound that directly reaches the sensoneural pathway, that is the bone conduction. Is that very clear? So always, what is better? Air conduction is always better than bone conduction. Is that very clear? Yes. This is what we test by the tuning fork test. So if you have understood this, you will understand all the tuning fork tests. So have you understood this? So quickly tell me, if the sound that I am speaking, if it is going through your air conduction, it is going through which pathway? Yes, it is going through all the three pathway, conductive plus sensory plus neural. If the sound that is going through your bone conduction, something directly through vibrating the bone, that is going through the bone conduction, it is mainly going through which pathway? It is going through which pathway? Yes, it is going through the sensory and the neural pathway. What will be better, air conduction or bone conduction? Air conduction. Why? Because of middle ear, because of amplification at the middle ear. Okay. So now let us start with the tuning fork test. Now the most preliminary tuning fork test that we do is Rinne's. Now what do we do in Rinne's is we test the air conduction and the bone conduction and we compare. We compare what is louder. Yes. So now in Rinne's what we are doing is we vibrate the tuning fork, we compare the air conduction, we do the bone conduction, we do the air conduction, we compare what is louder. Now if the air conduction is better than bone conduction, air conduction is better than bone conduction, we call it as Rinne's is positive. Yes. So can you tell me Rinne's will be positive in which condition? In which condition will air conduction be better than bone conduction? Yes, in normal ears. Normal ears, normally air conduction is better than bone conduction. Okay, now tell me, what is the common pathway for air conduction and bone conduction? What is common to both air conduction and bone conduction? Which pathway is common? Can you see here which is common? Yes, the sensorineural pathway. Sensorineural pathway is common. It is common to both air conduction and bone conduction. Yes, which means if there is a sensorineural hearing loss, if there is a sensorineural defect, will it affect both the air conduction and bone conduction? Yes, it will affect both. So if there is a sensorineural hearing loss, will the air conduction go down? Yes, it will go down. Will the bone conduction also go down? Yes, that will also go down, which will still be better. Both have decreased, which will still be better. Think and tell me. Yes. Again, air conduction will be better. Why? Because in air conduction, because of amplification and the middle ear, more of sound is reaching the defective inner ear than the sound that is directly going to the defective inner ear in bone conduction. So again, if there is a sensorineural hearing loss, then air conduction will be better than bone conduction. That is exactly what I told you in the beginning also. Did I tell you that as long as the middle ear is normal and the sound is passing through the normal middle ear, air conduction will be better than bone conduction? Did I not tell you that? Yes. Middle ear is normal gives us two situations. Everything is normal. Middle ear is also normal, inner ear is also normal. In that case, air conduction will be better than bone conduction. That is normal ear. And middle ear is normal, but sensorineural pathway is defective. Middle ear has to be normal. Yes. So middle ear is normal, inner ear is also normal. Very good. Middle ear is normal, inner ear is defective. Still amplified sound is going to the defective inner ear. So again, air conduction will be better than bone conduction. So in both these cases, air conduction is better than bone conduction. So in both these cases, Rinne's is positive. So whenever Rinne's is positive, two things should come to our mind. Which two things? Quickly tell me which two things? Normal and sensorineural hearing loss. Normal and sensorineural hearing loss. Okay, now what if the bone conduction is better than air conduction? Yes, if the bone conduction is good, bone conduction signifies what? Yes, bone conduction signifies what? Sensorineural pathway. Yes, so from now onwards, the moment we say bone conduction, immediately what should come to our mind? Sensorineural pathway. So if the bone conduction is better than air conduction, means bone conduction is good. Bone conduction is good. So sensorineural pathway is good. So if the sensorineural pathway is good, where is the defect? Yes, the conductive pathway. So if the bone conduction is better than air conduction, then we call it as Rinne's negative. And Rinne's will be negative in conductive hearing loss. Yes. So if the bone conduction is better than air conduction, we call it as negative. If it is, so this, okay, conductive hearing loss. Now, just listen very attentively, okay, very careful. Now, here is a patient who has a severe defect in the right ear of the sensorineural pathway. The sensorineural pathway in the right ear is severely defective. Yes. So, when you're testing the tuning fork test, when you vibrate and you test the air conduction, the sensorineural pathway, that is the inner ear, the nerves, severely defective. Will you hear this little sound of the tuning fork? No. Ultimately, whatever sound, it has to go through the sensorineural pathway. That's the common pathway. Whether it goes through the middle ear, whether it goes directly, ultimately sensorineural pathway has to be involved for hearing. So if this is so loud, so little, the sound is so little and the sensorineural pathway is completely gone, will he hear the air conduction? No, he will not hear. Will he hear the bone conduction? No, he should not hear. Why did I say he should not hear? Because he should not hear, but he hears. Why does he hear? Because when in bone conduction the skull vibrates, both the cochlear fluids move. So when the opposite ear, which is good, that cochlear fluids also move, that senses the hearing. So now what happens is patient senses the hearing through the other ear. That is known as transcranial transmission of sound. We do not know he is sensing from which ear. When we tested the air conduction, he says, no, I am not hearing. When we tested the bone conduction, he says, yes, I am hearing. So what is the result that we have got? We have got the result, bone conduction is better than air conduction. Bone conduction is better than air conduction means that bone conduction is good. Bone conduction is good, so what is good? Sensorineural pathway is good. So why is the defect? Conductive hearing loss. But is the patient actually having a conductive hearing loss? No, patient is not having a conductive hearing loss. So this negative Rinese is false. This is falsely telling you patient does not have a conductive hearing loss, but it is telling you that patient has a conductive hearing loss. So this is false. This is a false negative Rinese. So Rinese, if it is negative, it can be either conductive hearing loss or it can be severe sensorineural hearing loss of 1 ear. It can be a severe, okay, not a simple sensorineural hearing loss. If it is simple sensorineural hearing loss, then it is, Rinese will be positive. Are you getting that? If it is just a hearing loss which is more than 70 decibel is what we call as severe sensorineural hearing loss. So if there is a hearing loss less than that, then patient will have air conduction because of amplification better than bone conduction. But if it is more than that, inner ear is totally gone, inner ear is not sensing only, whether it is air conduction or bone conduction. But patient is perceiving the bone conduction through the other ear. So because of that, we are getting a false negative Rinese. So severe sensorineural hearing loss, this is known as false negative. False negative. Now this false negative Rinese is a very, very frequent question of your exams. Almost every year, either directly, indirectly, this is asked, and this is considered as a medical emergency. Now, why is it considered as a medical emergency and why it is asked so commonly in your exam? Because it is an emergency, it is considered as, it is asked so commonly, and everybody sitting in the ENT OPD should be knowing this, that if the Rinese is negative, two things have to come to our mind. Which two things? Either a conductive hearing loss or a severe sensorineural hearing loss. Now, let us understand this. Now, what is the meaning of conductive hearing loss? Conductive hearing loss means where is the defect? It can be anywhere from the pinna, external aortic canal, middle ear up till the footplate of stapes. If there is any defect in the pinna or the external aortic canal or the tympanic membrane or the ossicular chain in the middle ear, can we correct it? Yes, we can. What is the meaning of sensorineural hearing loss? Sensorineural hearing loss means the defect is in the inner ear, that is the organ of Corti, or in the nerve. Now, what's the meaning of a severe sensorineural hearing loss? Severe sensorineural hearing loss, how does it occur? Yes, it is usually the end stage of any disease which led to a sensorineural hearing loss. Maybe it is a Meniere's, maybe it is a caustic neuroma, which led to a sensorineural involvement, and that is late in this disease that the patient will have a severe involvement, severe sensorineural hearing loss. So that itself tells us that even sensorineural hearing loss most of the time is not reversible, and if it has become severe because of these diseases, which is the end stage, definitely it is not reversible. But there is one condition which can lead to severe sensorineural hearing loss occurring suddenly. That is known as sudden severe sensorineural hearing loss. Now, how can severe sensorineural hearing loss occur suddenly? What can you think of? Yes, why the hearing loss has totally gone suddenly? Yes, because of that occurs very commonly because of viral infections. Because of viral infection, what has happened as the nerve has got involved, because of which there is edema, there is ischemia, and there is immediate loss of hearing. The nerve has got severely affected and there is loss of hearing. Now, this is one severe sensorineural hearing loss which can be reverted back to normal. Yes, reverted back to normal, but only if the treatment is given immediately. What treatment do we give for edema? Steroids. So if the steroids are started immediately, then this hearing loss can come back to more or less normal. And what more if we can bring the hearing back of any patient to normal? Now just understand the significance. You are sitting in the ENT OPD. Here is a patient who has come to you with a complaint that, doctor, till yesterday I was good. I went to the market, I went to the office, I came back, I watched TV, I slept. Since morning, I feel that I'm not hearing properly. So, you have a look at the ear and you see that no, you're not finding anything. But patient says that he is having a hearing loss, so you take out a tuning fork test. You take out tuning fork and you do the tuning fork test. So you do the test the air conduction and the bone conduction, and what you see is that the bone conduction is better than air conduction. So when you see bone conduction is good, you're relieved. Bone conduction is good, sensorineural pathway is good. So this patient has what hearing loss? Sensorineural pathway is good. Defect is in the conductive pathway. So you think that maybe he, because of allergy or maybe temperature change, maybe his eustachian tube is getting blocked. He is having some conductive pathology, and the patient has come to you too early. Till yesterday he was okay only. So maybe he has come too early for any changes to appear in the ear. You give him antiallergics. You send him. After 1 week, the patient comes to you again that I've been taking antiallergics for a week, but I don't feel any improvement. And you see the ear again you're not seeing anything. Again, you take out your tuning fork, you do Rinese, and again what you find is bone conduction is better than air conduction. So again you feel, okay, bone conduction is good, sensorineural pathway is good, defect is in the conductive pathway, I'm not seeing anything. You give antibiotic and you increase the dose of antiallergic. And the patient goes back again. After 1 week, he comes back again, no improvement. And now when you do the Rinese again and you see again that the bone conduction is better than air conduction, and now what comes to your mind is the patient having a severe sensorineural hearing loss? And after 2 weeks or 3 weeks, even if you have been able to find out that the patient is having a severe sensorineural hearing loss, you have lost it. You have lost the patient. You have lost the hearing. Yes, and it is because of your negligence. Because of your negligence, the patient has lost his hearing. So it is of utmost responsibility for anybody who is sitting in the ENT OPD to know that if there is any Rinese which is coming negative, you do not have to think of one thing, only conductive hearing loss. You have to think of two things. It can be either conductive hearing loss or it can be a severe sensorineural hearing loss. And sitting in the OPD itself, you have to differentiate whether it is a conductive or a severe sensorineural hearing loss. And you must be thinking, okay, all these things, do they actually occur? They are for maybe exams or rarely. No, we find these patients, we get these patients almost every week, maybe, yes, even more. This is sometimes so common. Every month, definitely we get it. So, this was, last year, there was a student who sent me a message that, ma'am, in somewhere in January, I had severe some infection, following which one of my ear, the hearing loss was gone. Okay, the other ear at least is normal? No. He said that my other ear, when I was a child, I developed meningitis, because of which my hearing in that ear is already gone. I'm deaf in that ear. So this was the only hearing ear, and in this year, in somewhere in January, he had messaged me somewhere in the beginning of April that somewhere in the end of January, I had this cold and some viral infection, following which my hearing reduced, and I thought that maybe it is because of the infection going to the ear, maybe something. I took antiallergics and I took the treatment, and I was studying, I was preparing, exams were near. So what I did is, when it did not improve, I went to the ENT. And when I went to the ENT, it was found out that I had a severe sensorineural hearing loss in this ear. So yes, he was not messaging me to find out that how should I treat it, because he knew that it could not be treated. And his 1 year is already gone, the other year now severe sensorineural hearing loss. What was his concern? His concern was that, ma'am, the prerequisite for PG entrance is that I should be able to use a steth. So if I go for cochlear implantation done, will I be able to use a steth? What do you think? No. These type of customized stats are not available in India. Outside also they are available with a lot of difficulty, which means this person who is a doctor, who has given the entrance to be a doctor, who has spent his all 5 years for preparing for being a doctor, now preparing for the entrance. Now, because of his hearing he will not be able to practice as a doctor now. Yes, so he will have to change his profession. So do you understand how important it is for anybody sitting in the ENT OPD to know that if anybody has decreased hearing, and even if the tuning fork test is showing a negative, don't think only of conductive hearing loss. Rule out a severe sensorineural hearing loss there and then, because if it's a severe sensorineural hearing loss, if you are losing time, you're losing the hearing of the patient. So how do we differentiate whether it is a conductive hearing loss or it is a severe sensorineural hearing loss? That you can do in the OPD itself, and that you can do by Weber's. That is the next tuning fork test. Now what you do in Weber's? Yes, what you do in Weber's is you vibrate the tuning fork and you place it either over the forehead or over the vertex or over the teeth, and what you look for is lateralization of sound. Now, what's the meaning of lateralization of sound? Lateralization of sound means in which ear the patient is hearing the sound louder. Now, Weber's is a very sensitive test. Even if there is a difference of 5 decibel in both the ears has conductive hearing loss, or both ears has sensorineural hearing loss, and there is a difference of only 5 decibel, it will tell you which is the better ear, it will tell you which is the worst ear. Whereas Rinne's is not a very sensitive test. Rinne's becomes negative only if the hearing loss is more than 15 decibel. Which means that if the hearing loss is less than 15 decibel, Rinne's will show that the hearing is normal. It does not pick up any hearing loss which is less than 15 decibel. So Rinne's becomes negative only if the hearing loss is more than 15 decibel. Yes, whereas Weber's is a very sensitive test. Okay, now what do we do in Weber's? Yes, so let us see what do we do in Weber's. When we are testing, we are placing the tuning fork over the forehead or over the vertex. You first tell me, what are we testing? Are we testing the air conduction or the bone conduction? We are placing the tuning fork here or here. What are we testing? We are testing the sound is going through the vibration of bone. So we are testing the bone conduction. Very good. Which means we are testing which pathway? We are testing the bone conduction is a measure of which pathway? Sensorineural pathway. Excellent. Yes. So we are testing the sensorineural pathway. Yes. So the mnemonic of Weber's is SOCS. SOCS. What is SOCS? If there is a sensorineural hearing loss of 1 ear, Weber's is lateralized to the opposite ear. Whereas if there is a conductive hearing loss of 1 ear, Weber's is lateralized to the same ear. Now this is just a mnemonic. Why this mnemonic I have given you? Because in the end, during the exams, maybe you are a little confused, you are anxious. So that is the time that if you remember the mnemonic, immediately you can come. But if you have understood it, you do not require this mnemonic. So let us understand it. Okay. So, and when you practice it again and again, the mnemonic is never needed. So let us see. When you place the tuning fork at the forehead or over the vertex, what we are testing is the bone conduction. Bone conduction is a measure of sensorineural pathway. Now, if there is a defect in the sensorineural pathway in the right ear, yes, so what will happen? When I am placing the tuning fork here, this sound is going through the sensorineural pathway of both the ears. So in the right ear, the sensorineural pathway is defective. So I will hear the sound louder in which ear? Yes, in the better ear. In the left ear, that is the ear with the better sensorineural pathway, because this is tensing the sensorineural pathway. So the ear which has the better sensorineural pathway, that will hear the sound as louder. Was that simple? Yes. So if there is, that is what this mnemonic tells you, that if there is a sensorineural hearing loss in 1 ear, Weber's is lateralized to the opposite side, that is towards the better ear. Whereas if there is a conductive hearing loss of one side, okay. Now if there is a conductive hearing loss of one side, suppose in my ear, if both my sensorineural pathway is normal, Both my sensorial pathway is normal. So now when I test the Weber's, both my sensorial pathway is normal, so it is going equally in both the ears. So I will hear the sound equally in both the ears, or I will maybe not appreciate that it is, that is why I will not appreciate that I am hearing better in some ear. It will be equal in both the ears. Now suppose if I have a conductive hearing loss in one ear, suppose I have a wax. Yes, so what will happen? Any conductive hearing loss we know is from pinna to foot plate of stapes. Any conductive hearing loss, suppose I have wax in my right ear, then I will hear the sound louder in the ear in which I have conductive hearing loss, louder in the ear in which I have wax. Why so? Okay, close the ears, open your ears and say okay, softly, yes, so that the sound goes only through your vibration of bone conduction. Say say. Yes, when are you hearing that sound louder? When you close your ear or when you open your ear? Close your ear, open your ear. Say, yes, when you close your ear, which means when you give yourself a conductive hearing loss, you are hearing the sound louder. Yes, why so? Why so? Yes, so when you are putting the tuning fork here, the sound is going through the bone conduction, that is the sensorial pathway in both the ears. Now, when the sound is going through the sensorial pathway of my left ear, my right ear has wax, yes, my left ear is normal. So, when it is going through the sensorial pathway of my left ear, what happens is, because my left ear is normal, some external sound of vehicles, of people talking, yes, of AC, of fan, everything, that is also entering my ear. So, that sound which is entering the ear at the same time also has to go through the sensorial pathway. So, through which this sound is going. So, now that sound will interfere with this sound which is going through the sensorial pathway. Whereas in my right ear, there is a conductive block. When the sound is going through the sensorial pathway of my right ear, the external sound is blocked because of the conductive block. Because of wax, the external sound is not able to go. Because of the conductive hearing loss, this external sound is not able to go. So, I am hearing this sound, the sound that I am hearing in this ear will be louder because that is not getting interfered by the external sound. So, is that clear? So, whenever there is a conductive block of one ear, in that particular sound, when we test the Weber's, it is not interfered by the external ambient sound. So, that will be heard as better because that is the only sound that is going through a sensorial pathway of that particular ear. So, that is what this tells you, that whenever there is a conductive hearing loss of one ear, Weber's will be towards the same ear. Same ear is which ear? The worst ear. Same ear is the worst ear. So, if you understand this much about Reni's and Weber's, you can answer many questions, yes. Okay, so before that, before we proceed, you are going to quickly tell me if there is a conductive hearing loss of the right ear. Weber's will be towards which ear? Yes, the right ear. If there is a sensorial hearing loss of the right ear, Weber's will be towards which ear? Towards the left ear. Okay, so let us do a few questions that are asked in your exams, that have been asked in fact in your exam. Patient complains of decreased hearing of the right ear. So, we are talking about the right ear. In the question it is given, there is decreased hearing of the right ear, okay. So, now we do not have to find out which ear is defective, we have to find out, let us see what is asked, okay. So, decreased hearing of the right ear, Reni's in the right ear is negative. So, whenever we see a tuning fork test, what is the approach? How do we approach it? Yes, this is the only way of approach. Yes, the moment we see negative, the moment we see positive, immediately we will write down what comes to our mind. If Reni's is positive, how many things can come to our mind? Two things. Which two things? Normal and sensorial hearing loss. Very good. If there is Reni's negative, how many things will come to our mind? Two things. Which two things? Tell me. Yes, conductive hearing loss and severe sensorineural hearing loss. So, here it is negative. So, two things have come to our mind, conductive hearing loss and a severe sensorineural hearing loss. Okay, so now Weber's is given. We are waiting for Weber's to differentiate what it is. Weber's is towards the left. Weber's is towards the left. So, now differentiate whether it's a conductive or a severe sensorineural hearing loss. Reni's in the right ear is negative. Weber's is towards the left. So, Weber's is towards the left, it means the sensorial pathway in the left ear is better. So, what is the defect here? Yes, so now the diagnosis is a severe sensorineural hearing loss. Is that clear? Let us come to the next question. Patient complains of decreased hearing in the right ear. Decreased hearing in the right ear, okay. Release in the right ear is negative, okay, again negative, okay. So again, the moment we see negative and positive, before reading the next word of the question, write it. Write what comes to your mind. Only two things will come to your mind. Only two things have to come. If more are coming, yes, delete it. Only two things have to come to your mind. Two things for any is positive, two things for any is negative. And if you do not write it, by the end, by the time you have reached the end of the question, you are totally baffled and you feel, leave it. Yes. So two things, just write it down. Yes, conductive hearing loss and a severe sensorial hearing loss. And now you look for Weber's. Yes. And now Weber's is towards the right. Decreased hearing of the right ear. Rene's is negative. Two things have come to mind. Weber's is towards the right. So why is the patient hearing this sound, sensorial sound, louder in a particular ear? In this ear? Yes. If the patient is hearing sound louder in this ear, it can be that either the sensorial pathway of this ear is better than the other, which means the other ear has sensorial hearing loss, or this ear has a conductive hearing loss. Yes or no? Or this ear has a conductive hearing loss. That can be the only two possibilities. If Weber's is to the right ear, yes, we have two possibilities only. Either it is a right conductive hearing loss or it is a left sensorial hearing loss. Yes or no? Yes, if the Weber's is towards the right, it can be a right conductive hearing loss, or it can be a left, or it can be a left sensorial hearing loss. That sensorial hearing loss can be a simple sensorial hearing loss, it can be a severe sensorial hearing loss, any affection of the sensorial pathway. So now here, yes, Weber's is to the right. So now what is the defect? Right conductive hearing loss. We do not have the option of left sensorial hearing loss. Why? Because it is given decreased hearing of the right ear. We are talking about the right ear. The right ear is defective. Is that clear? Okay, so now let us see a few more questions. Before we go to a few more questions, let me ask you this. Okay, if there is a serous otitis media in one ear, what will be the hearing loss? Serous otitis media is what? Fluid in the middle ear. What hearing loss? Conductive hearing loss. Very good. Okay, if there is otosclerosis in the right ear, otosclerosis in the right ear, yes, again, it is conductive hearing loss. Meniere's is what hearing loss? Endolymphatic hydrops, sensory, okay, let us call it sensorineural. Acoustic neuroma, nerve, neuroma, yes, okay, sensorineural, okay. So, answer these questions for me, yes, sit straight, yes, answer. Right here, serous otitis media. Rene's in the right ear. Rene's, conductive hearing loss, okay, Rene's will be negative. Only two things you have to think, no? Yes, okay. So, negative. Rene's is negative. Weber's right serous otitis media, right conductive hearing loss, yes, towards the right side, because there is a conductive block, external sound not coming and interfering with this sound. Right otosclerosis, Rene's, Rene's, again negative. Weber's, right otosclerosis, conductive hearing loss, so right, yes, it is towards the right side. Right Meniere's, Rene's, positive, yes, because it is sensorial hearing loss. Rene's is positive in which two conditions? Normal and sensorial hearing loss. Weber's, right Meniere's, sensorial hearing loss, the sound will be heard better in the better sensorial, towards the left ear. Very good. Now tell me acoustic neuroma. Right acoustic neuroma, Rene's, positive, negative? Rene's, positive. Weber's, yes, to the opposite side, Is that clear? Okay. Okay, now answer this question for me. Yes. So, in a patient of decreased hearing, now here is not given which ear. Yes, it is just given decreased hearing. Decreased hearing, what is given is Rene's in the right ear is negative. So, right ear Rene's is negative and in the left ear Rene's is positive. So, should we go to see the choices, or before that you want to write something? Yes, I have told you that before writing down, the moment you see Rene's and Weber's, we are not going to proceed. Yes. Okay, so Rene's negative, the moment I see negative, two things will come to our mind. What is coming to your mind? Yes, same thing is coming in my mind also. Okay, yes, it is conductive hearing loss or severe sensorineural hearing loss. Okay, Rene's is in the left ear positive. In the left ear is positive. Now what is coming to your mind? Yes, very good. What is coming? Normal and sensorial hearing loss. Very good. I can see you're so intelligent, no? Yes, okay. So, now let us see the DD. We have already done only these can be diagnosis. 2 diagnoses we have in the right ear, 2 diagnoses in the left ear. Okay. So 40 decibel conductive hearing loss in the left ear. Left ear, do we have any option for conductive hearing loss? No. Incorrect. Bilateral 40 decibel conductive hearing loss in the right ear. Yes, conductive hearing loss is a possibility. Left ear? No. No scene of conductive hearing loss. Wrong. Not a possibility. Left severe sensorineural hearing loss. Left sensorineural hearing loss can be there. Severe cannot be there. So no. And right ear normal? No. Not a possibility. Okay. Right severe sensorineural hearing loss? Yes. Left ear normal? Yes. So this is the answer. So this was a question of AIIMS, and when it was asked, okay, 40 decibel conductive hearing loss in the left ear, bilateral conductive hearing loss, 40 decibel left severe. My God, I'm having vertigo. Leave this question. AIIMS, no, has to be difficult. Is this difficult? No. To answer this question, you need to know only 2 things. Rinese is positive in which 2 things? Rinese is negative in which 2 things? Is that not? Not even Weber's is expected here. Yes? Now let me ask you another question. In right middle ear pathology, this was another question. Right middle ear pathology, Weber's is towards. Yes, so first you need to know right middle ear pathology means what hearing loss? Yes, conductive hearing loss. So simply they are asking in a different way. Yes, in right conductive hearing loss, Weber's is towards. Yes, towards the right side. Right middle ear pathology, Weber's is towards right side. Right external ear pathology, Weber's is towards right ear. Right inner ear pathology, Weber's will be towards the left ear. Yes, because of the sensorineural pathway in the other ear being better. Is that clear? Have you understood the Rinese and Weber's? Is that very clear? Let us do one more question. Okay. A 38-year-old gentleman reports of decreased hearing. Yes, because rest of the questions, you have all the MCQs, you do that. But when you do these MCQs, there's a specific pattern that I want you to follow here. And because these are questions that are asked every time, so I have put a few MCQs here. Now, 38-year-old gentleman reports of decreased hearing in the right ear. Okay, so what is the ear that is affected? Right ear. This will mark. Decreased hearing in the right ear, which means we are now sure left is normal. We are only dealing with the right ear. There is decreased hearing in the right ear that we are talking. In the last 2 years, on testing with 512 tuning fork, Rinese test is negative, okay, on the right ear. So now we will write it, okay. So in the right ear we will write, and in the left ear we will write. Rinese in the right ear is, Rinese is the right ear, this is the left ear. Rinese in the right ear is negative. Okay, Rinese in the right ear is negative. What we will do now? Now we will immediately write down what 2 things are coming to our mind. What is coming to our mind? Conductive hearing loss or a severe sensorineural hearing loss is coming to the mind. And left ear, what is given? Left ear is positive anyway. It has to be positive, no? In the left ear, because left ear it is already given, it is normal. Decreased hearing is only of the right ear. But anyway, it is positive. So anything positive, it is anyway given, it is normal. So we can just write normal also here, or still if you want to think that if it is not given, if it is not given that there is decreased hearing of which ear, if it is just given these findings, then how we go about. Okay, so we will write normal, and here we will write a sensorineural hearing loss. Only these 2 options we have. Okay, now Weber's is perceived louder in the left ear. Okay, so Weber's is towards left. So if the Weber's is towards the left, we have 2 possibility. In the left, yes, there is 2 possibility now. In the left, there can be either a conductive hearing loss, or in the right, there can be a sensorineural hearing loss or severe sensorineural hearing loss, whatever. Yes, a sensorineural or a severe sensorineural hearing loss. Now let us see. In the left ear, is conductive hearing loss a possibility? No. So this is out. This is out. In the right ear, is sensorineural hearing loss a possibility? Yes. So what's the diagnosis? The diagnosis is right severe sensorineural hearing loss. Do we have it in the choice? Yes, we have right severe sensorineural hearing loss. So I hope you have understood the Rinese and Weber's properly. We have done it so well now. When you open your questions and do it. Only then you will know whether you are able to answer it or not correctly. Yes? Okay, so now we have some more tuning fork tests which we need to know. One is known as ABC. ABC. I will tell you only the full form of ABC. ABC is known as absolute bone conduction. Absolute bone conduction. Rest everything about ABC test you are going to tell me. Okay, tell me. ABC is a test for which pathway? It is absolute bone conduction. So it is a test for bone conduction, which means it is a test of which pathway? Yes, the sensorial pathway. If in any patient, I am giving you the result. In this patient, ABC is less. ABC is shortened. What is that meaning? What does that mean? Yes, ABC is shortened means what is shortened? Bone conduction is shortened. So what defect does the patient have? Sensorial hearing loss. Bone conduction is a measure of sensorial pathway. So if the ABC is shortened, it is what? It is sensorial hearing loss. Now I will tell you how we do the test. So what you saw is, if you just know the name of this test and you know what is bone conduction, you know how to interpret this test. But still I am telling you how to do this test. So what we do in this test is we compare the hearing of the patient with the examiner, considering that the examiner's hearing is normal. So the name has absolute in it. Absolute, why absolute? Because we are testing only the bone conduction. So how are we excluding the air conduction pathway? Yes, when we are testing in ourselves, we block the tragus. When we are testing in the patient, we block his tragus. Means we are giving both of us a conductive hearing loss. So conductive pathway is excluded. We are already having a conductive hearing loss, that is assumed. So what we are testing now is a sensorial pathway. So what we do, how we do this test is, I vibrate the tuning fork and I place it over the mastoid of the patient, which means I am testing his what? Over the mastoid, bone conduction. Very good. Which pathway? Sensorial pathway. And while I am doing this, I close his tragus. Now the moment the patient stops hearing, he tells me that I have stopped hearing. I immediately take it and I place it over my mastoid, I close my tragus. Patient has stopped hearing, I am still hearing. Patient has stopped hearing, I am still hearing. It means that my sensorial pathway is better than the patient's sensorial pathway. Since mine is normal, patient's sensorial pathway is less. Yes? So if the ABC is shortened, ABC is less. Less than whom? Less than mine. Less than normal. Yes? So if it is less, or I call it as shortened, then I say patient has what hearing loss? Patient has a sensorial hearing loss. Okay. Now, can this test a conductive hearing loss? No, it cannot test a conductive hearing loss because we are giving both of us already a conductive hearing loss. Now, if the ABC, if the patient's sensorial pathway, he stopped hearing, I also place it on my mastoid and I also not hearing. I also stop hearing. So, it means that patient's and my hearing is normal, is same. So, since I am normal, he is also normal. So, if the ABC is same. Now, if the ABC is same, it indicates that patient has normal hearing. Patient's hearing is normal. Patient's hearing is normal. So, the extension of ABC test is what is known as Schaubeck. Schaubeck. Yes, so what is the difference of ABC and Schaubeck? The test is absolutely ditto same. The only difference is that we are not closing the tragus. So when we are not closing the tragus, we can also test the conductive pathway in this. So how do we do this again? Same. It is just an extension of ABC test. Yes, so what we do is, we vibrate the tuning fork, considering that the examiner is normal. I vibrate the tuning fork, I place it over the mastoid of the patient. I am not closing his tragus. So when I place it over the mastoid of the patient, I am testing his bone conduction. Bone conduction means which pathway am I testing? Yes, I am testing the sensorial pathway. The moment he stops hearing, I place it over my mastoid. He has stopped hearing, I am still hearing. I am still hearing. It means his bone conduction is less than mine. So mine is normal, he has what hearing loss? His sensorial pathway is less than mine. So he has a sensorial hearing loss. So till here it was the same like ABC, no? Yes, so Schaubeck also, if it is decreased or it is shortened, it is the same like ABC. It is sensorial hearing loss. But there is an extension to this. What is the extension? Now when I place it over patient's mastoid, he stops hearing, I place it over my mastoid, I am also not hearing. Now what I do is I reverse it. I first vibrate the tuning fork and place it over my mastoid. I stop hearing, I immediately place it over the patient's mastoid. I have stopped hearing, patient is still hearing. What? Where is the defect? Here? Boss is always the boss. If patient is hearing less, he is defective. If I am hearing less, who is defective? Patient. How? Yes, because if my hearing is normal. That was a prerequisite. If my hearing is normal and the patient is hearing the sound better than me, how is that possible? Why is he hearing the sound better than me? Because he has a conductive hearing loss in his ear. In my ear, when I am testing the sound, because my conductive pathway is normal, some external sound is going and interfering with this sound. Whereas in patient's ear, the external sound is not able to go inside because of the conductive block. So the only sound that he is hearing is this bone conduction sound. It is not getting interfered by the external ambient sound. So he is hearing the sound louder than me. So if the Schwabach is increased, or I can say it is louder, it is for a more duration, it is increased, it is lengthened. It is lengthened, then it is conductive hearing loss. And that was the same reason why Weber's was also getting lateralized to the conductive side. Weber's was also getting lateralized to the conductive side because it was, because of the conductive block, the external sound was not interfering with this sound. So this is what is Schwabach. Yes. So now quickly, yes, keep down your pen. Tell me, right ear cirrhosis media renitis. Right ear cirrhosis media renitis. Negative. Weber's, right cirrhosis media, Weber's, right side. ABC, ABC. Right serous otitis media, ABC. Is ABC a test for conductive hearing loss? No. So it will be normal. Schwabach, right serous otitis media, lengthened. Yes. Right otosclerosis renitis, negative. Weber's, to the right. ABC is for bone conduction, normal. Schwabach, lengthened. Right Meniere's, yes, right Meniere's, renitis, positive. Weber's, sensorineural hearing loss towards better sensorineural, to the left. ABC, absolute bone conduction, it is Meniere, sensorineural defect, yes, it will be shortened. Schwabach, yes, for sensorineural hearing loss, ABC and Schwabach is same, so it will be shortened. ABC cannot be lengthened, yes, that is only for it is only for sensorineural hearing loss, it is not for it is not for conductive hearing loss. ABC is only for sensorineural hearing loss, it is not for conductive hearing loss. Okay, so right acoustic neuroma renitis, positive. Weber's, towards the left. ABC, shortened. Schwabach, also shortened. Now let us do this question. So now let us do this question. Yes, let us read the question. In a patient, Reni's test is positive. Reni's test is positive. So, or it can be given as air conduction better than bone conduction. Whatever is given in the question, we know it is the same thing, yes. Even if it is given air conduction better than bone conduction, don't get confused. Don't panic, what is this now? Yes, air conduction better than bone conduction is Reni's positive. Okay, in both the ears. So what we will do is, next, before proceeding, we are going to immediately write down, that is the only way. So, in the right ear, we will write, in the left ear, in the right ear, in the left ear. Reni's is positive, so we have two possibilities, normal or sensorineural hearing loss. Again, it is positive, so again it can be normal or sensorineural hearing loss. Okay, so now Weber's is towards the right. So if the Weber's is towards the right, Weber's is towards the right means right is the better ear. If right is the better ear, what is the defective ear? Defective ear is the left. So if the defective ear is the left, what is the diagnosis? Yes, left sensorineural hearing loss. That's the diagnosis. Now let us see what the choices say. Yes, so the choices are saying that no intervention required as both the ears are normal. No, both the ears are normal, then Weber's will not lateralize. Remove wax from the right ear. So this is incorrect. Remove wax from the right ear. Remove wax from the right ear. Where did wax come? Yes. You know why wax is given here? Remove wax from the right ear. Because the moment you see that Weber's lateralized to the right, and if you have not written it like this, that there is no possibility of a conductive hearing loss, Reni's positive, only normal or sensorineural hearing loss. Again, Reni's positive, only normal or sensorineural hearing loss. If you have not written it down, then what will happen? The moment you see wax from the right ear, you will think, okay, wax in the right ear. Yes, they have given Weber's is towards the right. So Weber's is towards the right. So there is two possibility. Either in the right ear there is a conductive hearing loss, or in the left ear there is a sensorineural hearing loss. So then you think that, okay, this is a conductive hearing loss of the right ear, and you mark this as the answer. Whereas if you have written it that Reni's is positive in both the ears, we do not have any scope for conductive hearing loss. cannot be conductive hearing loss in any ear, or right or left, wherever. No conductive hearing loss, no wax. That is wrong. Repeat the Rennie's test. Now, when you have already done the Rennie's test, what you will get by repeating it? Why not do a test that will reconfirm the Rennie's, that will reconfirm whether it is sensorineural hearing loss, that will reconfirm whether it is a conductive hearing loss. Yes? So, when we have got a conductive hearing loss, you can reconfirm it. When we have got a sensorineural hearing loss, you can still reconfirm it. By what test? Sensorineural, we can reconfirm by ABC as well as Schwabach. In conductive, we can reconfirm only by Schwabach. So here, since it is a sensorineural hearing loss, we can do either ABC or Schwabach. But ABC is not given in the choice. So what's the answer? Schwabach. So repeat Rennie's test? No. Yes. So can you see that the tuning fork test, once you have understood and once you approach it in a proper pattern, it becomes so simple to answer. So now that we have done all the tuning fork tests and we have revised it also beautifully, a mention of a few tests is required, which is yes, not done commonly now because we have so much better tests, but still it is a mention is required because yes, sometimes it is asked in your exam. So the first of that is the Galley's test. Galley's. Now, what is the Galley's test? Yes, now in this test, we vibrate the tuning fork, we place it over the mastoid, and at the same time, what we do is we take a Seagull speculum. I hope you have seen what a Seagull speculum looks like. It is a rubber bulb attached to a tube. This tube we can attach to the otoscope. So when we press the bulb, the pressure of external auditory canal increases, and when we release the bulb, the pressure comes back to normal. So now when we press the bulb and the pressure of the external auditory canal increases, what happens is that the tympanic membrane is pushed inside, which means that the tympanic membrane gets retracted, so the ossicular chain mobility gets hampered. This leads to decreased hearing. When we increase the pressure, when we bring it back to normal, now the tympanic membrane comes back to normal, the mobility of the ossicular chain comes back to normal, and the hearing again becomes normal. Now, if we increase and decrease the pressure while the patient is being given the sound, patient says that there is a change in hearing. He hears less, then it becomes good. He hears less, then it becomes good. But what if the ossicular chain is already fixed? If the ossicular chain is already fixed, will increasing or decreasing the pressure have any change on the ossicular chain mobility? No, it is already fixed. So if you increase and decrease the pressure and the patient reports no change in hearing, whether on increasing or decreasing, it is an indication that the ossicular chain is already fixed. So what is the most common fixation that we know of? Yes, that is the fixation of footplate of stapes. That is what is known as otosclerosis. So yes, this Galley's test was an important test for otosclerosis, for diagnosis of otosclerosis, but now we have many better tests for otosclerosis. So yes, what you need to know in Galley's is two things. First, it is a test, it is done for otosclerosis. And the second is that in otosclerosis, when you do, what will be Galley's? Yes, there will be no change in hearing. So that is what is known as Galley's negative. Negative means no change in hearing. No change in hearing, whether you increase or decrease on increasing or decreasing the pressure of external auditory canal. When you increase and decrease and there is a change in hearing, that is what is known as that the test is positive. That is normal. Whereas if it is negative, it means that there is no change in hearing. That is indication of otosclerosis. Now another test which requires a mention here is the Bing's test. Bing's test. Now what is this Bing's test? In Bing's test, we are pressing and releasing the tragus while the sound is being given to the patient. Now when we press the tragus, what happens is we get a conductive hearing loss. When we release the tragus, then the external auditory canal becomes normal. So what this test is, now in us, do this and see for yourself. When you press and release the tragus, when you give yourself a conductive hearing loss, and then when you release it, when you're speaking itself, when you're speaking that sound that you're speaking itself, you can see that there's a change in hearing. When you press, you speak, you hear louder because you're giving yourself a conductive hearing loss. The external sound is not entering and going into the inner ear and interfering with the sound that we did in the tuning fork. Yes. So when you release, what happens is, the external aortic canal comes back to normal. So there is a change in hearing. When we press and when we release, if our external aortic canal is normal, we experience a change in hearing. But what if the external aortic canal is blocked, or if the patient already has a conductive hearing loss? So if the patient already has a conductive hearing loss, whether you give this conductive hearing loss or not will not matter. Patient already has a conductive hearing loss. So when the patient already has a conductive hearing loss, when you press or release will not make a difference. So the patient will not report any change in hearing. So Bing's test, if there is no change on pressing and releasing the tragus, it means that there is a conductive hearing loss. Whereas if there is a change in hearing, when you press and release the tragus, it means that the ear is normal. So do it now for yourself and see when you are pressing and releasing your tragus, when you are giving yourself a conductive hearing loss, and when you are releasing that, whether you are experiencing a change in hearing or not of your own voice. So if you are experiencing a change, it means that your ear is normal. If there is no change, it means that you have a conductive hearing loss. So that is what is Bing's test. So Gillies and Bing's, yes, not very commonly asked, but yes, can be asked sometimes. So quickly, can you tell me, Gillies is a test for what? Yes, for autostosis. And in autostosis, when you press and release the Seeger speculum, when you increase and decrease the pressure of external aortic canal, will there be any change in hearing? No change, because increasing or decreasing will not alter the movement of the tympanic membrane. It is already fixed. Same for Bing's test. If there is a conductive hearing loss, when you press and release the tragus, will there be any change in hearing? No change in hearing. So if there is no change in hearing, it means that the patient has a conductive hearing loss. Otherwise, we say that it is normal. So this is what ends the tuning fork test.